It's my pleasure to be here. I've no T therapy disclosures, except I was chairman of the AOA Testosterone Guidelines panel, and that publication came out in 2018. It's been updated last year with no dramatic changes in the statements. For those of you who heard me talk over the last couple of days, I'm become very enamored with this term, obsessive oncocentricity. In the prostate cancer space, the obsession about PSA at the kind of discrediting or ignoring quality of life issues, and I'm a quality of life physician. So the definition of high-risk prostate cancer for us is Gleason grade grouping 4+, so Gleason sum 8, 9, or 10, or adverse pathology, positive margins, seminal vesicles, lymph node involvement, irrespective of the Gleason grade grouping, and those patients who have biochemical recurrence, irrespective of pathology. I think you're all very familiar with the concept of the saturation model, that when there are androgen-sensitive prostate cancer cells in a petri dish, when they have no testosterone, they do not proliferate. And then when you give them testosterone and you follow that on the x-axis logarithmically, they proliferate in a linear fashion. And then at a certain point, known as the threshold point, saturation level, they become agnostic to increased levels of T. And this is what's represented here by curve C. Interestingly, in the more modern era, over the last 5 years or so, Sam Denmead, who's a medical oncologist at Hopkins, has shown that if you continue to give testosterone to those cells, they actually stop proliferating. That's called a bipolar androgen therapy concept. This is the diagrammatic representation of this petri dish with LNCAP, so testosterone-sensitive cells. And you can see as the concentration on the x-axis increases, you get to a point, the saturation point, where the cells stop proliferating. So in clinical terms, whether your T level, let's say, is 250 nanograms per deciliter, or whether it's 750 nanograms per deciliter, shouldn't make a difference to a prostate cell, benign or malignant. It's the Shally-Bassines data from a trial which was published quite some time ago, 20 plus years ago. On the x-axis, you'll see weekly dosing of testosterone up to very high doses, 600 milligrams per week. The blue bar is the testosterone level. Of course, you see rise dramatically. And then the PSA level you'll see doesn't change much at all. This is Jose Flores data from our center, which we published a couple of years ago. And this is looking at pre-prostatectomy, men with prostate cancer, PSA levels on the x-axis. And then you look at the pre-prostatectomy testosterone levels on the y-axis. And you'll see as the patient's PSA level drops below 5, there is an increasing risk of that patient having low testosterone levels. And that relationship where low PSA predicts low T is most notable in those patients who have high-risk prostate cancer. That solid line there is Gleason 8+ cancer, all pathology included. So this is the dogma. This is the foundation for the concept that testosterone adds fuel to the fire. This is the Huggins and Hodges data from the 40s, and this was intramuscular testosterone given to 3 men with metastatic prostate cancer. Results in this paper were only reported for 2 of the patients, one of whom was already castrated. By definition, was significantly below the saturation point. And in that case, you're expecting that when you give them testosterone, that there's going to be some effect on any prostate cancer cell present. So essentially, there was one relevant non-castrate patient in this series of 3. And of course, no PSA in that era. It was serum prostatic acid phosphatase, and that rose with TTH. And this is the foundation for the labeling for testosterone products, which says you shouldn't give testosterone to prostate cancer patients. The AUA guidelines, published in 2018, has 3 statements on the prostate. Number 1, that you should measure PSA in men who are 40 years of age or older before instituting T therapy. This was an interesting discussion at the council level, in the sense that we went to Ballantyne Carter, who was at Hopkins at the time, and who was the chair of the prostate cancer early screening panel at the AUA. And we had this discussion, and it was agreed between himself and myself that what we would do is not just protect the patient, but that we would protect also the prescribing physicians, so that you should have a PSA available in men 40 years or older just in case it is elevated. If it is elevated, then further, more detailed evaluation of that patient. Statement number 17 was there is an absence of evidence linking testosterone therapy to the development of men with development of prostate cancer. So these are men who don't have diagnosed prostate cancer. You put them on T. There is no evidence to show that prostate cancer rates increase. And then 18 was for prostate cancer patients. For prostate cancer patients with testosterone deficiency, there is inadequate evidence to quantify the risk-benefit ratio of TTH. And I think that still remains a true statement because the estimates are you need about 85,000 men for 15 years to answer the question, is T therapy safe in the prostate cancer population? This is Morgan Taylor's data. Total T on the left, free T on the right, and you'll see when total T levels are low, you have higher rates of prostate cancer prevalence. And in fact, the literature supporting the concept that low T predicts higher stage and higher grade prostate cancer is pretty robust. This is Lenny Mark's data. On the top is the serum T levels. On the bottom, the prostate tissue levels. This is a randomized controlled trial, small number of patients. Testosterone therapy on the left side, placebo on the right. And you can see in the serum panels, you get the expected rise in testosterone when men are given testosterone therapy. But if you look at the bottom panel and look at prostate tissue changes in testosterone, you do not see any changes. That while there are serum changes, that does not eke its way into the prostate. This is the reverse study, of course, the very recent study, $500 million study, half sponsored by AbbVie Pharmaceuticals, driven by the FDA, and looking primarily at major adverse cardiovascular events. But there was a prostate angle to this, and this is the prostate safety study, which was published with no increased risk in high-grade prostate cancer, no increased risk in any prostate cancer development, no increased risk of acute urinary retention or invasive procedure for BPH. So I think we can, with 5,400 men analyzed, randomized controlled trial, I think we can say safely now that testosterone therapy in the non-prostate cancer population does not increase the risk of prostate cancer. This is the contemporary literature in testosterone therapy in men after prostatectomy. The upper four rows are for low-grade cancer, and then the bottom four rows are those studies that include men with high-risk prostate cancer. You can see that with rare exceptions, with the exception of the Tom Ehlering study at the top and the Alex Pasasak study when he was at Baylor in low-grade prostate cancer patients, the studies are very small, 10 and 7 patients, 47, 26, etc. If you look at the biochemical recurrence rate, there is a signal here that if you give testosterone therapy to men with post-prostatectomy, whether they have organ-confined cancer or not, that actually the recurrence rates is lower in those men who get testosterone therapy. Now, I'm not going to stand up here and say that we can reduce prostate cancer recurrence rates in men who get testosterone therapy, because there's a major methodologic flaw in every one of these studies, and it is that they do not account for the concept of immortal time bias, which is a very important concept in observational studies, which I'm happy to answer questions about in a few minutes if you wish. So, we have just published in the Journal of Urology our first testosterone therapy paper, prostatectomy patients, organ-confined, Gleason 6, Gleason 7, 3 plus 4, 4 plus 3, organ-confined cancer. And these are the numbers, as you can see here. This is the 5-year Kaplan-Meier curve showing no increase in biochemical recurrence rates in those patients exposed to T therapy versus those men who did not get T therapy. Overlapping graphs, as you can see here. What's very interesting is if you look at the 10-year Kaplan-Meier curve, given all the limitations involved there, there's actually a lower risk of biochemical recurrence, taking into account immortal time bias now. First study to do that in the literature, lower risk of biochemical recurrence in those patients getting T therapy. If you look at the raw data, Gleason grade grouping 1, 2, and 3, you'll see the no T therapy biochemical recurrence rates and the T therapy biochemical recurrence rates with no significant difference. Okay, this is not a randomized controlled trial. Men on T versus men who are not on T. So this is our high-risk data. The definition I gave you at the very beginning, our high-risk patients, the first row is biochemical recurrence rates. As you would expect, they're very high. High-risk prostate cancer, 65–70% biochemical recurrence rates over a 5 to 10 year period. And you can look at this population of men with normal T, high-risk disease, and that's about 500 now. Men with testosterone deficiency who did not opt for testosterone therapy, about 250 men. And testosterone deficiency, getting testosterone therapy, 150 men. And if you look at the biochemical recurrence rates there, you would say, wow, the biochemical recurrence rates are lower in those patients who are getting testosterone therapy. If you look at the time to biochemical recurrence, something very interesting appears. That while the biochemical recurrence rates are lower in those men getting testosterone therapy, they occur at an earlier time point, perhaps supportive of the concept that you need testosterone to generate a PSA response. So lower rates of biochemical recurrence in those getting testosterone therapy, but quicker onset of that PSA elevation. And you can see the mean follow-up rates here of about 4 years, which is actually pretty good for men with high-risk disease because many of them get recurrence in a shorter period of time than that. So this is an impressive Kaplan-Meier curve, at least visually. It's statistically significant. The red line are those men who have testosterone deficiency, high-risk prostate cancer, who get testosterone therapy. And while we can't come out yet and say that testosterone therapy is protective against biochemical recurrence in men with high-risk prostate cancer after prostatectomy, I think you would all accept that certainly there's no increased risk based on this graphic here. I'm going to give you a case scenario, a 65-year-old man with long-standing testosterone deficiency who was on testosterone therapy prior to his prostatectomy. Seen 6 months after his prostatectomy, Gleason 4+4, so high-risk disease. His PSA post-op is undetectable, but his total T level was 111. Remember, he was on testosterone therapy for years prior to his prostatectomy. And so the question that I could pose to all of us and to our oncologists is, what's his real PSA level? He's below saturation point. Is there a chance that he does not have enough T to actually generate PSA? And I think the answer to that question is yes, that's a grave concern. So he could go lead the rest of his life at T levels of this level and have prostate cancer growing in the background because he doesn't have enough T to generate a PSA response. So there are many post-prostatectomy and post-radiation patients with T levels below saturation point. The classic example is radiation plus ADT and a man who's left at castrate level, where a concern could be raised about what is their true PSA level? Is the PSA in front of you in the setting of very low testosterone, is that real? Is that the real PSA? What we do with these men is we give them an intramuscular testosterone challenge, and if the PSA rises, that becomes an oncological discussion. I'm talking about the post-prostatectomy patients now. If the PSA doesn't rise, I say, Mr. Jones, I believe you're a candidate for testosterone therapy. What's very interesting, what remains a conundrum even at MSK, is if the PSA is non-detectable and the patient goes on testosterone therapy and it's stable, but in time the PSA rises, should we stop the testosterone therapy? Because if you stop the testosterone therapy and he drops below saturation point, you're going to expect the PSA to drop. And is that a false sense of security? Or should we continue the man on testosterone therapy if the oncologist is going to use the PSA as a metric for further investigation, like a PSMA scan, or further intervention, such as, let's say, post-prostatectomy radiation plus or minus androgen deprivation therapy? All but one of our prostatectomists allow us to continue the testosterone therapy in this patient population, and they monitor the PSA and respond accordingly, because I've I think, convinced them that the real PSA level is when the testosterone level is replete. I think you're familiar with the testosterone checklist. We can skip over that. So the MSK-CC, John Mulhall, testosterone therapy philosophy and the appropriately selected candidate. Testosterone therapy is a shared decision between clinician and patient. Beware the impact of testosterone deficiency on survival. You have a patient with Gleason 3+3, 3+4 organ-confined cancer with potentially 20+ years of life ahead of them, but have very low T levels. It is possible that their life will be shortened not by their prostate cancer, but by their testosterone deficiency. I think I've discussed the T and PSA concept with you enough, and then let's avoid being overly oncocentric. Thank you very much.